Hello, I am Dr. WAFAEY Badawy, consultant histopathologist. I'll be talking about endometrial carcinoma. Definition and general background. It is a malignant epithelial neoplasm originating from the endometrium. Endometrial carcinoma is the most common malignant tumor of the female genital tract in high-income countries. It is the fourth most common cancer in women in the developed world. It is the sixth most common cause of cancer mortality in women. Most cases arises in the postmenopausal period with a mean age at presentation of 6 years. Most patients, approximately 90%, present with abnormal uterine bleeding, such as hypermenorrhea, menometrorrhagia, postmenopausal bleeding. Some patients are diagnosed after an abnormal cervicovaginal cytology result, that is pap smear. The presence of endometrial cells in pap smears of women over the age of 45 years needs to be reported. Classification of endometrial carcinoma. Endometrial carcinomas have been traditionally divided into two types, type 1 and type 2. Type 1 including endometrioid carcinoma, the usual type. It is the most common subtype of endometrial carcinoma. The subtypes including vello-glandular carcinoma, secretory carcinoma, ciliated cell carcinoma, endometrioid carcinoma with non-villous papillae, endometrioid carcinoma with the squamous differentiation, mucin-rich endometrioid carcinoma, mucinous carcinoma. Type 2, it is also called non-endometrioid carcinomas, including Serous Adenocarcinoma. It is the prototype for type 2 endometrial carcinomas. Glia cell carcinoma, carcinosarcoma, pure squamous cell carcinoma, undifferentiated carcinoma. This grouping was helpful in understanding the pathogenesis of endometrial cancer, but this is not a histopathologic classification. What are the aggressive types of endometrial carcinoma? They include serous adenocarcinoma, Glia cell carcinoma, undifferentiated carcinoma, pure squamous cell carcinoma, undifferentiated carcinoma. I am going to talk about endometrioid carcinoma and its subtypes. Definition and general background. Endometrioid carcinoma is the most common subtype, accounting for 80% to 85% of endometrial carcinomas. It is considered to be estrogen dependent with a defined precursor lesions. Typical patients are obese, hypertensive, diabetic, perimenopausal or postmenopausal women, mean age 60 years. However, 5% occur in women less than 40 years of age, including rarely adolescents. Rare tumors have occurred in pregnant women. Women less than 45 years of age have a better prognosis as their tumors tended to be low stage and low grade. Endometrioid adenocarcinoma can occur in the cervix, vagina, ovaries, and elsewhere, such as stomach and prostate. Clinical and general features. The typical symptoms is postmenopausal bleeding or abnormal bleeding in a premenopausal woman. The uterus may be enlarged. An elevated serum CA 125 level may be found, especially in women with high stage disease. Extrauterine disease, that is stage 3 or 4, is present in less than 10% of cases. Unlike serous carcinoma, peritoneal spread at presentation is rare. In 5% of cases, there is a synchronous endometrioid carcinoma of the ovary. Radiographic features. Sonographic features are non-specific, and endometrial thickening can also be due to benign proliferation, endometrial hyperplasia, and polyp. Ultrasound features that are suggestive of endometrial carcinoma rather than hyperplasia include heterogeneous and irregular endometrial thickening, polypoid mass lesion, intrauterine fluid collection, frank myometrial invasion. Here in this photo, we can see heterogeneous and irregular endometrial thickening. Here we can see polypoid mass lesion. A thickened endometrium requires endometrial sampling. MRI is recommended for optimal disease extension assessment and is considered superior to CT for local staging. Here in these photos, we see large irregular polypoidal mass nearly fills the endometrial cavity. The mass invades and obliterates the junctional zone posteriorly and minimally extends to the myometrium. Risk factors of type 1. These lesions are associated with long-term elevated estrogen levels, that is unopposed estrogen stimulation, which lead to persistent proliferative stimulation of the endometrium. Risk factors leading to hyperestrogenism include obesity, exogenous hormonal therapy such as tamoxifen used for breast cancer, ovarian cortical hyperplasia, hyperthecosis, polycystic ovarian syndrome, chronic anovulation, estrogen secreting ovarian tumors, for example, granulosa cell tumor, prior pelvic irradiation, usually for cervical carcinoma, endometrioid carcinomas arising in women with hereditary non-polyposis colonic carcinoma. It is called Lynch Syndrome. Precursor lesions of endometrioid carcinoma. Endometrial hyperplasia without atypia. The risk of progression to carcinoma is low, up to 4.6% of cases without hysterectomy after 20-year follow-up. Atypical hyperplasia, endometrioid intraepithelial neoplasia. It is associated with progression to endometrioid adenocarcinoma in up to 28% of cases without hysterectomy after 20-year follow-up. Concurrent endometrial carcinoma occurs in up to 43% of cases. However, the majority are low-grade Figo, grade 1, and low-stage Figo, stage 1A or 1B. Definitive treatment of atypical hyperplasia endometrioid intraepithelial neoplasia is hysterectomy. Progestin therapy for fertility preservation. Gross appearances. Here we can see broad-based polypoid masses. Here we can see highly infiltrating diffusely into the myometrium. In general, extensive myometrial invasion is accompanied by clinically detectable uterine enlargement. Microscopic appearance. It is typically composed of tubular glands, most of which are of medium size, but can range from small to large and cystic. The glands are generally round to oval, but may be angulated or branched. Nuclear atypia. The nuclear features of malignancy include round nuclei, variation in shape and size, variation in staining, hyperchromasia, coarsely clumped chromatin, prominent nucleoli, frequent mitosis, abnormal mitosis. Significant nuclear atypia, if present, increases the tumor grade. Grading. The Figo system divides this tumor into 3 grades depending on the ratio of glandular to solid elements. Grade 1. Well differentiated, almost only neoplastic gland with minimal less than 5% solid areas. Grade 2. Moderately differentiated, 5% to 50% of malignant epithelium forms glands. Grade 3. Poorly differentiated, large, more than 50% areas of solid tumor. Significant nuclear atypia, if present, increases the tumor grade. Significant nuclear atypia changes a grade 1 tumor to grade 2 and a grade 2 tumor to grade 3. Grade 2 endometrioid adenocarcinoma. Here we can see the architecture is that of grade 1 adenocarcinoma. That is extreme end of the spectrum. But the degree of cytologic atypia warrants an overall grade of 2, moderately differentiated. Here in the left photo, we can see complex budding and branching of glands separated only by thin wisps of stroma. Here we can see focal severe nuclear pleomorphism, hyperchromatism, and prominent nucleoli. Immunohistochemical studies for endometrioid carcinoma. They show diffuse nuclear estrogen expression, diffuse nuclear progesterone expression, diffuse nuclear PAX8 expression, diffuse cytoplasmic vimentin expression. Endometrioid carcinoma subtypes, including glandular carcinoma, secretory carcinoma, ciliated cell carcinoma, endometrioid carcinoma with small non-villous papillae, endometrioid carcinoma with squamous differentiation, mucin-rich endometrioid carcinoma, Mucinous carcinoma. Glandular endometrioid carcinoma. It is the most common endometrioid carcinoma with a papillary pattern. It accounts for 13% and 31% of endometrioid carcinomas. As many as 40% of the tumors are mixed with typical endometrioid carcinoma. The villous pattern can occur in myoinvasive foci, but is usually most conspicuous in superficial tumor. The tumors are characterized by often long, slender villous papillae with thin fibrovascular cores, usually admixed with a variable proportion of endometrioid glands, although rare tumors are purely or almost purely villous. The cells lining the villi and glands show low-grade cytologic atypia that is well differentiated grade 1 endometrioid carcinoma. So glandular endometrioid carcinoma is almost always grade 1. Endometrioid adenocarcinoma, secretory type, secretory carcinoma. This variant usually occurs in premenopausal women. It is an extremely well differentiated but otherwise typical endometrial adenocarcinoma. It occurs usually as a result of progesterone stimulation. Large subnuclear vacuoles of glycogen occur in some cases owing to progesterone stimulation. It resembles that of a normal 17-day secretory endometrium. It is accompanied by a late secretory pattern in the adjacent non-involved endometrium. It may be diffusely or focally in a well-differentiated endometrioid carcinoma. It should be distinguished from clear cell carcinoma, which will be described later. It has the most favorable prognosis. Secretory carcinoma. Secretory carcinoma is composed of cells with abundant clear to finely granular cytoplasm, mainly large subnuclear vacuoles. Ciliated cell carcinoma is an extremely rare neoplasm in which the invasive glands are lined by cells with cilia along the luminal border. Its significance lies in the recognition that cilia do not always indicate a benign lesion. Here in these two photos, we can see endometrioid adenocarcinoma with prominent ciliated cells projecting into the luminal spaces. That is ciliated cell variant of endometrioid carcinoma. I must say that its significance lies in the recognition that cilia do not always indicate a benign lesion. Endometrioid carcinomas with small non-villous papillae. The papillae in these tumors lack fibrovascular cores, and their constituent cells have distinctive brightly eosinophilic cytoplasm. It shows intraglandular papillary enfoldings composed of cells with abundant eosinophilic cytoplasm and round bland nuclei. The cells have metablastic-like appearance. It may be associated with endometrial hyperplasia, which displays dilated glands with intraglandular papillary tufts and detached cell clusters. Endometrioid adenocarcinoma with squamous differentiation. It refers to endometrioid adenocarcinoma containing squamous elements, that is, squamous morules, derived from metaplasia of the tumor glands. It is called adenoacanthoma if benign squamous components, that is, well-formed squamous morules. It is called adenosquamous carcinoma if malignant squamous components. The squamous component has markedly atypical cytologic features, that is, a poorly formed squamous morule. However, WHO recommends that the terms adenoacanthoma and adenosquamous carcinoma should no longer be used because there are no prognostic differences between pure endometrioid adenocarcinomas, adenoacanthomas, and adenosquamous carcinomas when compared stage by stage and grade by grade. Mucin-rich endometrioid carcinoma. Here in this photo, there is luminant mucin in endometrioid adenocarcinomas. It's common and may be prominent. Luminant mucin mucin in endometrioid adenocarcinomas is common and may be prominent. So it is called mucin-rich endometrioid carcinoma. Endometrioid carcinoma with mucinous metaplasia. Mucin is usually absent or confined to luminal tips of cells, but minor foci of mucinous differentiation, that is, cells with abundant intracellular mucin, are present in almost half of the conventional endometrial endometrioid carcinoma. Here we see glands with moderate myxoid intraepithelial mucin, appreciable on low power. 50. Conventional, here in this photo we see conventional endometrioid carcinoma in a top half with malignant glands containing abundant intraepithelial and extravasated intraluminal mucin in lower half. Mucinous carcinoma. It is typically of low grade and is the least common type of endometrial adenocarcinoma. Mucinous carcinoma of the endometrium has a glandular architecture resembling endometrioid carcinoma but is composed of cells containing abundant intracytoplasmic mucin. It is cytoplasmic, that is mucinous differentiation, not extracellular, and luminal, that establishes the diagnosis of endometrial mucinous carcinoma. The presence of cytoplasmic mucin should be extensive, involving greater than 50% of the cells, for a tumor to be classified as mucinous carcinoma. Mucinous carcinoma. In this Figo grade 1 tumor, the gland cells have abundant cytoplasmic mucin. Nuclei are oriented along the basal portion of the cells, resulting in a resemblance to endocervical epithelium. High power shows abundant luminal mucin and basal alignment of the nuclei with minimal nuclear stratification. Up to 9% of all stage 1 endometrioid carcinomas are of the mucinous type when strict criteria are applied. Differential diagnosis of endometrial mucinous carcinoma. The distinction between endometrial mucinous adenocarcinoma and primary endocervical endocarcinoma can be made based on immune stains. Features that favor a primary endocervical origin are the following: presence of in situ adenocarcinoma in the cervical glands, negativity for vimentin, negativity or only weak positivity for estrogen or progesterone receptor expression in both HPV associated and HPV independent adenocarcinomas of gastric type, presence of HPV nucleic acid by in situ hybridization or PCR, block positive immunoreactivity for P16, that is strong nuclear and cytoplasmic positivity characteristic of most HPV-associated endocervical adenocarcinomas of usual type. Mucinous carcinoma. Mucinous adenocarcinoma with intestinal goblet cell differentiation. Type 2 non-endometrioid carcinomas, including serous adenocarcinoma. It is the broad type for type 2 endometrial carcinomas. clear cell carcinoma, carcinosarcoma, pure squamous cell carcinoma, undifferentiated carcinoma. Serous carcinoma. Serous carcinoma is a relatively uncommon type of endometrial carcinoma, accounting for about 5% to 10% of cases. The mean patient age is 70 years. It is an especially aggressive variant, and the patients tend to have a poor prognosis due to usually high nuclear grade, advanced stage of disease, that is stage 2 or 3 disease, deep myometrial invasion in 40% to 50%, frequent vascular space invasion, a predilection for peritoneal spread, similar to primary ovarian serous adenocarcinoma. It has a 25% to 35% 5-year survival rate and a 14% 10-year survival rate. Lung and liver are the most common sites of metastasis in advanced stage serous carcinoma of the endometrium. Uterine serous carcinoma. These tumors exhibit complex papillae, highly stratified cells, and epithelial buds. A defining feature of this lesion is the presence of cells with diffusely high-grade malignant features. As illustrated here, these features include macronucleoli, multinucleated tumor germ cells, marked hyperchromatism, frequent mitosis, and nucleomegaly, that is nuclear grade 3. It has a distinct immune profile that is strong and diffuse nuclear staining for p53. Immunohistochemistry of uterine serous carcinoma. Here we can see serous carcinoma glandular pattern. It shows a strong and diffuse nuclear staining for p53. It is the most common staining pattern in serous carcinomas. Here we can see a strong and diffuse nuclear and cytoplasmic positive p16 immunolabeling of high-grade malignant glandular cells. Here we see patchy cytoplasmic positive vimentin. When we compare it with the classic endometrioid carcinoma, which shows diffuse positive vimentin. Serous endometrial intraepithelial carcinoma. It is the putative precursor lesion of serous carcinoma. It is seen in atrophic endometrium of older postmenopausal women. Here in this photo, we can see several glands. These glands are lined by cells with high-grade nuclei interspersed among atrophic glands. The nuclei are stratified with papillary tufts. The lesion is characterized by cells that show marked nuclear abnormalities identical to that seen in serous carcinoma of the endometrium. yet lagging an invasive component. The serous endometrial intraepithelial carcinoma cells display markedly atypical nuclei with high nuclear cytoplasmic ratio, multiple prominent nucleoli, and numerous mitotic figures. Tufting is common as the cells become discohesive. This photo shows apparent nuclear expression of p53 protein that is a strong and diffuse pattern. In the high-grade nuclei, it is called mutant pattern. Here we can see diffuse nuclear and cytoplasmic p16 immunolabeling. However, in a subset of cases of serous endometrial intraepithelial carcinoma, shows a complete absence of p53 expression. It is called null pattern due to a loss of function of p53 mutation. SEIC is often found in the presence of frank invasive carcinoma, typically serous type. SEIC or serous carcinoma confined to the endometrium generally has a good prognosis. However, a few cases have metastases involving intrauterine organs. Glia cell carcinoma. It accounts for less than 5% of all endometrial carcinomas. It is a tumor of postmenopausal patients. It is associated with an increased risk for thromboembolic events. It is associated with a poor prognosis, 5-year survival rate of about 35%. Primary Glia cell carcinoma of the endometrium is histologically indistinguishable from Glia cell carcinoma in the ovary or in the cervicovaginal region of women exposed to diethylstilbestrol, DES. There is no known association between the development of endometrial Glia cell carcinoma and DES exposure. Microscopically, Glia cell carcinoma features a proliferation of polygonal cells with glia or eosinophilic cytoplasm, marked pleomorphism, and high-grade cytologic features. The cells contain variable but usually large amounts of glycogen. Regarding the architecture, it may show papillary architecture, glandular pattern, solid or sheet-like pattern, or a combination of these architectures. Polygonal hobnail and flat cells with moderate to abundant glia or eosinophilic cytoplasm. It is associated with the variable cytological atypia, low or high-grade mitotic index, pleomorphic nuclei with occasional large irregular nucleoli. The tumor cells nuclei often protrude into luminal space, giving rise to a hobnail or tombstone appearance. In these photos, we see admixed papillary and glandular architecture with glia cells and oxyphilic cells. The tumor cells nuclei often protrude into the luminal space, giving rise to a hobnail or a tombstone appearance. Immunohistochemistry of Glia cell carcinoma. Here we see napsin A expression in tumor cells with negative internal control. Here we see retained expression of MSH6. This is DNA mismatch repair enzyme gene, both in Glia cells carcinoma and adjacent benign gland. Please note that Glia cell and papillary serous adenocarcinomas represent approximately 10% of all endometrial cancers and are considered to be poor histopathologic subtypes. These subtypes tended to have deeply invasive myometrial involvement. They have a propensity for extrauterine spread, even though the myometrium may be superficially involved. Carcinosarcoma, malignant mixed Mullerian tumor. It is a highly malignant biphasic tumor consisting of both epithelial carcinoma and mesenchymal sarcoma components. This is an uncommon tumor of epithelial derivation, accounting for less than 5% of all uterine malignancies. It affects predominantly postmenopausal patients. Median age at diagnosis is about 65 years. As with endometrial carcinoma, the patient with carcinosarcoma typically presents with postmenopausal bleeding. Because it is of epithelial derivation, they are currently staged like endometrial carcinoma. Malignant epithelial components. It includes serous carcinoma. It is the most frequent epithelial elements. Glia cell, mucinous, undifferentiated carcinoma or squamous carcinoma. Sarcomatous components. It can display a variety of patterns that have been referred to as either homologous or heterologous. Homologous components. It shows differentiation toward the mesenchymal cells normally present in the uterus. The homologous sarcoma often resembles endometrial stromal sarcoma, leiomyosarcoma, fibrosarcoma, or malignant fibrous histiocytoma. Heterologous components. The sarcoma is considered heterologous when it is differentiated in two cell types not normally found in the uterus. The usual heterologous components are rhabdomyosarcoma, most common heterologous element, chondrosarcoma, osteosarcoma, or liposarcoma. Grossly, carcinosarcoma, malignant mixed Mullerian tumor, It shows solid, partially cystic and necrotic mass that expands the uterine cavity. Microscopically, usually the carcinomatous and sarcomatous components are intimately admixed, that is, biphasic pattern, with nests and masses of carcinoma separated by malignant spindle cells. Here in this photo, we can see endometrioid carcinoma overlying a malignant appearance sarcomatous stroma. Notice the marked atypical cytologic features of stromal cells and their abundant mitotic activity. Here we can see heterologous elements in the form of cartilage. Here we can see rhabdomyoblast heterologous elements, see the arrows, appearing as pleomorphic rounded cells with ample eosinophilic cytoplasm adjacent to malignant epithelium. What is the molecular classification for endometrial carcinomas? It encompasses 4 genomic subtypes: hypermutated microsatellite instability MSI, Paul ultramutated carcinomas, high copy number abnormalities or serous-like carcinomas, low copy number abnormalities. Hypermutated microsatellite instability MSI. They are characterized by loss of DNA mismatch protein repair and a high rate of mutations. Microsatellite unstable endometrial carcinomas, representing 3% to 4% of endometrial carcinomas, are part of the hereditary non-polyposis colorectal cancer or Lynch syndrome. In Lynch syndrome, patients often present at young age. It has an intermediate prognosis. Paul ultramutated carcinomas. They have 15-fold more mutations than the hypermutated tumors. Mutations almost invariably somatic in the polymerase epsilon gene. They have been associated with the morphologic poor prognostic features such as high-grade or ambiguous histology and the lymphatic invasion. Paradoxically, they have a very favorable outcome, and patients rarely relapse due to high numbers of CD3 and CD8 tumor-infiltrating lymphocytes, most of which demonstrate an endometrioid morphology with a subset of undifferentiated and dedifferentiated tumors also noted. High copy number abnormalities or serous-like carcinomas. They are characterized by large copy number alterations, most frequently P53 mutations, in more than 90%. Histologically, most tumors are serous carcinomas or grade 3 endometrioid carcinoma. Please note that it had the worst prognosis among all 4 groups. Low copy number abnormalities. All remaining samples that do not belong to the pol-ultra mutated group, the MSI group, or the high copy number group are termed low copy number abnormalities. It shows few mutations, low number of somatic copy number alterations. They are part of microsatellite stable carcinomas. Common abnormalities include P10, ARID1A, and CTNMB1 mutations. The vast majority of these tumors are endometrioid with intermediate prognosis. Microsatellite instability testing. MSI testing is done by screening for mismatch repair enzymes, MMR deficiency. A surrogate test for identification of tumors in this category is immunohistochemistry for mismatch repair enzymes, including MLH1, PMS2, MSH2, MSH6, which is increasingly preferred to MSI testing. Screening for DNA mismatch protein repair, MMRD, can be done by immunostaining for just 2 of the proteins, MSH6 and PMS2. If both are expressed, it means the tumor is MMR intact. In this photo, immunostaining shows loss of expression of MLH1 in the tumor cells, with retained expression in lymphocytes and stromal cells. Tumors from people with Lynch syndrome are likely to demonstrate loss of mismatch repair protein expression. We here can see loss of MLH1 and PMS2 expression. However, MSH2 and MSH6 are preserved, showing normal expression of mismatch enzyme, repair enzymes. In this case, immunohistochemical staining demonstrating loss of MSH6 expression in primary uterine endometrioid carcinoma with intact expression of MSH2, MLH1, and PMS2. It is important to remember that tumors with high mutation rates can give rise to large numbers of potential neoantigens. Pol-mutant endometrial cancers have a median number of predicted neoantigens that are almost 15-fold ultra-mutated higher compared with MSI tumor. MSI endometrial carcinomas are sevenfold, that is hypermutated, higher compared with microsatellite stable endometrial cancer. Another characteristic of both Pol mutant and MSI tumor is the presence of higher numbers of CD3 and CD8 tumor infiltrating lymphocytes compared with microsatellite stable tumor. Figo, 2009 staging of cancer of the endometrium. Figo stands for International Federation of Gynecology and Obstetrics. Stage 1. Tumor confined to the corpus uteri. 1A. No myometrial invasion. 1B. Tumor invades more than 50% of myometrium thickness. Stage 2. Tumor invades cervical stroma but does not extend beyond the uterus. Stage 3. Local and or regional spread of the tumor. Stage 3A. Tumor invades the serosa of the corpus uteri and or adnexa. 3B. Vaginal and or parametrial involvement. 3C. Metastasis to pelvic and or para-aortic lymph nodes. Stage 4. Tumor invades bladder and or bowel mucosa and or distant metastasis. 4A. Tumor invasion of the bladder and or bowel mucosa. 4B. Distant metastasis including intra-abdominal metastasis and or inguinal lymph nodes. Treatment. Standard management of endometrial cancer at diagnosis involves surgery followed by chemotherapy with a taxane and a platinum compound. For example, paclitaxel plus carboplatin and or radiation therapy. These are the references. Thank you.